Hi everybody, I'm Katie Gallacher. I'm speaking to you from Glasgow in Scotland, where the sun is actually shining. Doesn't happen all that much here, so we're very happy. So as Katie said, I'm just going to sort of present for 10, 12 minutes, and then we're going to have our panel discussion. So I'm going to basically summarise our paper that was recently published in Mayo Clinic Proceedings. And I'm going to talk about minimally disruptive medicine progress 10 years later. So we'll start off talking about the inception of the term minimally disruptive medicine, and then talk about the progress over the decade and the theories and the conceptual model that have added to our knowledge, and then some discussion about where we go from here. So the story began, as everybody knows, back in 2009 with this pivotal paper that was published in the BMJ by Carl, Victor, and Francis, called We Need Minimally Disruptive Medicine. And in this paper, the term burden of treatment was coined, as was the term minimally disruptive medicine. So this was laid out as healthcare that is effective yet realistic. Of course, it takes consideration of both burden of treatment and patient capacity. Importantly, it's patient-centered care, and of course, it's individualized to the patient. And for the first time, really, the authors laid out that non-compliance, as it's called, is not an illustration of a person inadequately prioritizing their health over other things. It's not patients just deciding that they can't be bothered, but it's often actually a symptom of the way in which healthcare services are configured and provided. So in other words, healthcare services can make it difficult for patients to follow treatments and manage their health. In the paper, there was 4 principles laid out to guide health services and research around the topic. So first of all, to establish the weight of the burden. So who is burdened, who is more at risk of burden, and how much are they burdened. To encourage coordination in clinical practice, because so much of the time, actually treatment burden arises from this, whether it's health services being poorly coordinated or healthcare professionals. Importantly, it was laid out that we should acknowledge comorbidity in clinical evidence and clinical guidelines. And this was done very poorly back in 2009. And to be honest, it has improved a little, but there's still a way to go with that. So often we're still treating single diseases rather than people with multiple conditions, which is commonplace. And lastly, and importantly, we were advised to prioritize from the patient perspective, which is so important for minimally disruptive medicine. So I'm going to talk about 3 theories and 1 conceptual model that have been used to really advance our understanding of minimally disruptive medicine over the decade. And of course, the people who created these theories are all in the audience, so quite a lot of pressure on me to get this right. But if anyone wants to chip in, or we can discuss this in the panel discussion at the end, but feel free to add in if you wish. So the 4 things I'm going to talk about are: the first is normalization process theory. Then I'll talk about theory of patient capacity, then the cumulative complexity model, and then burden of treatment theory. So the first is normalization process theory, or NPT, and this has been used to understand healthcare workload. So NPT was developed to understand how a set of tasks or processes can be embedded into everyday life. So in this case, it would be all the tasks involved in managing health. Now, I put this slide up. My colleague, Botesh Jani, I have to credit him. He created this cartoon bear. I think it just brings the domains to life. So I've used it on the slide with his permission. So there are 4 domains to NPT. The first is coherence. And in relation to healthcare workload, this refers to all the sense-making work that's done. So all the thinking and planning, you get information about your treatments, you make sense of this, you set goals, all the thinking that goes into that. And then we have cognitive participation. So this refers to relationship work. So you interact with a lot of different people when you're managing your health. That could be your friends and family who might take you to appointments, etc. And it could, of course, be health professionals, doctors, nurses, therapists. And then we have collective action. So this refers to the enacting work. So that's all the doing. That's the things that you do. So you attend appointments, you take your medications, you do your exercises, you stop smoking, you eat well, you make all these lifestyle changes. There's a lot of doing that goes into managing health. And then we have reflexive monitoring, which refers to reflective work. So of course that refers to monitoring your health and making changes. And that might be informally at home, or it may be more formally in a healthcare setting with your doctor or nurse. So MPT has really helped us to better understand the different aspects of healthcare workload. The thing about treatment burden is that it's subjective. So if you have two people and they're given the exact same healthcare workload, then they're likely to report feeling burdened differently. And in fact, one person may not feel burdened at all. Not everybody experiences treatment burden, and one may feel very heavily burdened. And part of the reason for this is that people have different abilities to be able to manage their health or patient capacity. So the theory of patient capacity has helped us to better understand all the different things that affect somebody's ability to manage their health. So theory of patient capacity has 5 domains, which I'll just run through. So the first is resources. So obviously resources are very important. You need to be able to access these and mobilize them. And these resources can be material, so for example, equipment, but importantly, they can also be personal resources such as self-efficacy or cognitive ability. So that's resources. And then we have social functioning. So the social network that you have around you can be very helpful to help you manage your health, or of course, it can hinder you managing your health if it's a difficult social network, or perhaps it might distract you and take up a lot of your time and energy. Then we have realization of work. So this refers to the fact that if you have successfully managed your health, then this gives you a boost, it gives you confidence, and it lets you go on and have further capacity to manage your health in different ways. Then we can see the bigger cog there is biography. So what is biography? Well, someone's biography, of course, is how they identify themselves and the course of their lives. And this can be very interrupted with chronic illness, and it can be changed. So it can be changed in a way that makes it more difficult, or it can be changed in a way that makes things easier, but it certainly can influence the ability you have to manage your health. And then you'll see the big box there is environment. So of course, that's the environment that you're managing your health in. So where do you live and what's the community that's around you? And of course, what health service are you using? Because that's very different in different countries. So the theory of patient capacity has really advanced our understanding of all the different factors that affect capacity. Now, workload and capacity are a balancing act, and both are constantly changing all the time. So at any one point in time, if workload exceeds capacity, then the person may feel overburdened and they may stop doing all the things that they need to do, which is often managing their health. So the cumulative complexity model has really helped us to understand this balance between workload and capacity. So you can see at the top, healthcare workload, and at the bottom, capacity. So if workload is too much and capacity is too little, then this affects how people access, utilize health services and how they look after themselves. So for example, if they're feeling overwhelmed, then they may stop taking their medications and they may stop looking after themselves properly. And this in turn affects outcomes. So for example, their blood pressure may go up or their blood sugars may rise. And this adds to their burden of illness because it may make them feel more unwell, and this lessens their capacity. And it also, what happens at this point is that when they see their healthcare provider, the healthcare provider wants to get those outcomes better. So they add medications, they add treatments in, they give them more appointments, they see them back sooner. And so that adds the burden of treatment and therefore escalates the problem. So what we want to do is at that point try to intervene to lessen treatment burden and have healthcare providers thinking about burden of treatment. So that's the cumulative complexity model. And then, of course, the third theory, which has vastly advanced our understanding of these concepts, is burden of treatment theory. So burden of treatment theory models the relationship between the person who's unwell, their relational network, and the health service that they're interacting in. And it really places an emphasis on how these 3 factors interact. It explains all the different processes and factors that affect how capacity is mobilized and then expressed. And then the mobilization for the delegation of tasks, healthcare tasks, and then the enactment of those tasks. So there's too much in burden of treatment theory to go through the whole thing, but let's take mobilizing capacity as an example at the top. So for somebody to mobilize their capacity, they have to have their own agency, so their own potential to do so. And then they're interacting with a social network, which can extend their agency, or of course it can make things harder for them. They're operating within a healthcare system, and the way that that health service is provided actually controls the ability that the person has to mobilize their capacity. And then lastly, they need opportunity. So for example, if they're going to use a health service, they need the opportunity to be able to use it. So what burden of treatment theory does is it breaks down these 4 processes into smaller chunks, which is very useful, because if you can intervene at any of these smaller processes, then you can actually lessen treatment burden. So it's very useful. Burden of treatment theory is extremely useful in aiding the development of interventions aimed at lessening burden of treatment. Okay, so I've outlined the 3 theories and the model that's helped us advance our knowledge. And now I'm just going to briefly talk about where we go from here, which can hopefully facilitate some discussion in the panel discussion. So what do we need to do? So to progress MDM, we need ways of measuring treatment burden and patient capacity. And then we need to develop interventions that are aimed at lessening burden and maximising capacity. So we do have some measures of treatment burden, which I'm sure many in the audience are aware of. We have different ones. Here are 3 on the slide, the TBQ, the PETs, and the MTBQ. You can see these vary in number of items and length and languages and ways they've been tested. And there's still ongoing testing being done of these measures. So we really are getting there with measurement of treatment burden. But unfortunately, as yet, we have no measures of patient capacity. So that's something that we really need to work on, and hopefully we can get onto that soon. And next, interventions. So what is an MDM intervention? What does it look like? It must put the person and their family at the centre of care. It has to provide care that's individualised to them. It has to acknowledge multimorbidity, and of course it has to minimise workload and maximise capacity. So examples of interventions which we've heard about already at this meeting. So for example, we've heard about the ICANN discussion aid, which was developed by colleagues at the Mayo. And this is an aid that can be used in the consultation to facilitate discussion about capacity. So that's very MDM focused. And similarly, capacity coaching is another intervention that was developed at the Mayo, and which is a type of health coaching with a focus on developing someone's capacity to manage their health. So just to summarise, we have come quite far over the decades. The conceptualisation of minimally disruptive medicine has really evolved, and we've used these 3 theories in a conceptual model. We have got methods of measuring treatment burden, and we're progressing with that, but we really do need to be able to measure patient capacity. And of course, we need to develop and test interventions aimed at lessening burden of treatment. Okay, so that's me. I'm just going to finish off with a photo of Glasgow for you to see.